بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is I think the sixth lecture in the course of musculoskeletal imaging, and here we will deal with the imaging of the hip joint. You know the common indications for examination of any joint, which include pain, trauma, swelling, and suspected inflammation or tumors. For evaluation of the hip joint, we use usually the body coil. Then we examine both hips at the same time. We examine the patient in the supine position. We may need fasting. We may need the patient to fast for 4 to 6 hours, especially whenever we are going to inject him with contrast media or to give him some sedation. You know the usual machines that we have, the closed magnet, the open MRI, and also the extremity magnet, which is not suitable for the examination of the hips. And here is the protocol of examination. Actually, we scan at slice thickness of 5 millimeter. We do not leave an interslice gaps on. We use a suitable field of view which ranges according to the patient size from 30 to 42 centimeter. Then the protocol should include coronal T1 and the coronal stare, axial proton density or T2 fat suppression or gradient image, and we have only one sagittal plane for the diseased hip, which I prefer to obtain in the T2 or the FATSat T2 weighted images. Then if we are going to inject the patient with contrast, we may have axial and coronal T1 weighted images after gadolinium injection. Then you know that the structures which appear black or of low signal in the T1 and T2 include the cortex of the bone, mature fibrous tissue, ligaments and tendons, as well as calcification. And we add here the acetabulum labrium, which is a fibrocartilaginous tissue, helps to deepen the acetabular fossa. The low signal lesions or structures in the T1, high in the T2 are the fluids, and in this particular example, the fluid in the urinary bladder, for example, is black in the T1 and bright in the T2 weighted image. The fat will be the opposite of fluid. It will show high signal in the T1 and less bright signal in the T2 weighted image. An example for the fat is the subcutaneous fat, the bone marrow fat, as you can see in this example. Then the T1 weighted images will show the bone marrow of bright signal because of the fat content, while the T2 will show the marrow less bright, and the gradient or FATSat images will show more dark bone marrow, and the stare images will show very dark signal of the bone marrow. Then the anatomy is relatively limited for this hip joint because there are almost no tendons around the joint, and we do not have so much anatomy in this particular area. This is the ball and socket joint. The acetabulum covers about 40% of the femoral head. A fibrocartilaginous labrium helps to increase the depth of the acetabulum, and the labrium is usually triangular in shape, and it appears beautifully in the sagittal as well as in the coronal images. It will show dark signal in all pulse sequences. And you should know that about 95% of the femoral neck is intra-articular in location. Then we would explain some of the anatomic details around the hip joint, but they are not essential to be memorized. Only whenever you are confronted by a lesion which affects one or more of the muscles around the hip, just open the book and look for the name of the muscle. And I would like to show some of the important muscles so that you are able to make an easier report. This is the one of the important muscles which lies in the pelvis against the acetabular floor, and that is the obturator internus muscle. And you should know that this muscle goes like this, and it has a component which is posterior to the hip joint as well. This very small muscle against the pubic ramus is the pectineus, and here is the femoral artery and vein. Then lateral to the vessels, you will see the iliopsoas muscle, and this is an important muscle to be known. Then more lateral to the iliopsoas, you will see the rectus femoris, and then the vastus lateralis, as well as the tensor fasciae lata. While anteriorly, you will see this muscle, which is the sartorius. Then what I want from you to remember, these two important muscles, the obturator internus muscle and the iliopsoas muscle. All of the remaining muscles, you can look at them in the book. And in the coronal images, I want from you to remember these three muscles in sequence. This is the obturator internus, and this is the obturator externus, and this is the adductor brevis. These three muscles which are attached to here to the pubic bone. Then you can see the adductor longus as well as the gracilis muscle. But these three muscles are important because they are frequently injured sometimes in patients who can ride bicycles, for example, for a long distance and so on. Then the approach for the hip joint is somewhat different from that of the knee joint, and it may be similar to that of the wrist joint. We approach the joint via the pathology, and these are the important issues we would like to discuss. The first one is the issue of avascular necrosis, transient osteoporosis, the Bursitt disease, developmental hip dysplasia, slip decapital femoral epiphysis, proximal focal femoral deficiency, and some cases of trauma and muscle injury. And we will end by some words about the labral tears, bursitis around the hip, loose bodies, and synovial osteochondromatosis. And finally, we will have some knowledge about the femoral neck anteversion angle and how to measure. Then let us start our discussion by the issue of vascular necrosis. And this vascular necrosis affects the femoral head, and the usual site is the anterolateral aspect of the head. However, any part of the head can be affected. MR is very sensitive and specific for the diagnosis of a vascular necrosis in the femoral head. And you know that the causes of a vascular necrosis anywhere in the body will include the trauma, the corticosteroids, sickle cell disease, alcoholism, radiation, and collagen diseases as well. Then how to look for the vascular necrosis in the plain X-ray. You know that there are certain signs for a vascular necrosis of the hip in the plain X-ray, which include contour irregularities and the fissures of the femoral head, areas of bone sclerosis and alternating with areas of bone rarefaction, As you can see here, there is a sclerotic bone and somewhat less dense bone compared to the apparently normal right femoral head. Also, by advancement of the disease, you got a structural collapse of the femoral head, and finally the joint will end by osteoarthritic changes. And this is a close view for the appearance of a vascular necrosis in the femoral head, which still shows regular contour, but there are patchy areas of bone sclerosis and rarefaction within the femoral head. And this is an advanced case of a vascular necrosis of the femoral head bilaterally, and you can see that the femoral heads are somewhat flattened. They present areas of bone sclerosis as well as areas of bone rarefaction. There is evident contour irregularity of the affected head. Then earlier vascular necrosis will manifest by subtle changes which can be overlooked in the plain X-ray, and they include some fissures in the subcortical bone like this one, and you may appreciate some increase in bone density of the affected head. This is advanced case of a vascular necrosis in a patient who is receiving steroid therapy for treatment of Crohn's disease. And here you can see that both femoral heads are involved by areas of bone sclerosis as well as areas of bone rarefaction. You see also osteoarthritic changes manifested by narrowing of the joint space and osteophytic clipping of the articular surfaces. Then the CT was of help in the diagnosis of vascular necrosis before the era of MRI, and the scan usually show the changes in the plain X-ray, but at a relatively earlier phase. Then here in the CT scan you can see that the femoral head on the left side is sclerotic, and it shows minimal contour irregularities compared to the normal femoral head on the right side, which is of normal bone density and regular outline. Then with the development of MRI, we are able to diagnose confidently the avascular necrosis, and there are stages for this avascular necrosis using a MRI classification, which include the stage 1, 2, 3, and 4. Actually, there is now a debate about if the stage 1 is really an existing stage in the classification or not, since most of the books depend on the presence of this line for the diagnosis of avascular necrosis, while in stage 1 it describes only bone marrow edema in the femoral head, and who are supporting this idea say that this edema will progress to the development of the line later on, and we are passing into an advanced stage of avascular necrosis. Then if we are convinced that bone marrow edema of the femoral head may represent stage 1 avascular necrosis, which can proceed in sometimes to the development of the line and starting the stages of the disease, we may consider bone marrow edema as a precursor for avascular necrosis in some patients and not in every case. Since this bone marrow edema may be diagnosed as migratory osteoporosis of the hip, and this migratory osteoporosis, as I will mention, is a self-limiting disease. It will resolve completely within 6 to 8 months, according to the literature. Then we consider sometimes that bone marrow edema may be a precursor for a vascular necrosis, and the development of a vascular necrosis in the femoral head, and the only diagnostic sign now considered in the literature is the presence of this low signal line in the femoral head. This low signal line will separate the dead bone from the viable bone. And according to the MR appearance or the MR signal of the dead bone, the classification will go on. Then, starting with stage 2, there is a line, and this line will separate the dead bone from the viable bone. If the dead bone is exactly similar to the viable bone in the signal intensity in both T1, T2, and stir images, then you consider stage 2, which is an early stage, as you can see. Then here, in the plain X-ray, you cannot appreciate any abnormality, but in the MRI, you can see the line indicating that you are in stage 2 at least. You look at the bone within the line, which is the dead bone. If it is similar to the viable bone, then you are dealing with stage 2 vascular necrosis. But if the dead bone is of fluid signal, as that's to say, it will appear black in the T1 weighted image, and so show some bright signal in the T2 weighted images. You see, this is T1 because the urine is black, and this is T2 because the urine is bright. Then, if you see this appearance, you may consider stage 3, where the dead bone is of signal similar to that of fluid. Then you see here, there is a line. The dead bone is almost similar to the viable bone. Then you are dealing with stage 2. The size and the location of the lesion will affect the prognosis. Lesions less than 25% of the weight-bearing area of the femoral head will respond to core decompression. And you know, one of the ways to treat a vascular necrosis is to have a core from the femoral head and the neck, and this core is removed, aiming at decrease the intraosseous pressure, which is supposed to be the cause for compromising the blood supply to the femoral head. Then medially and centrally located lesions will have better prognosis, and sometimes we may inject contrast media. In many cases of vascular necrosis everywhere in the joints, we may inject contrast media to assess the viability of the bone. Sometimes, if the bone will enhance, it means that there is still some viability in the suspected area. But if the plain X-ray showed this appearance, which means that you are in advanced stage, meaning that there is flattening and collapse of the femoral head, which is involved by bone sclerosis and rarefaction, together with irregularity of the femoral head contour. Then in stage 4 avascular necrosis, the dead bone will be sclerotic. That is to say, it will show low signal in the T1 and also low signal in stir images. And this stage will be associated with flattening and collapse of the femoral head, with possible development of the avascular of the osteoarthritic changes, as you can see here, with bone sclerosis of the opposing articular surfaces and narrowing of the joint space. This is stage 4 avascular necrosis by plain X-ray, MRI, T1, and the gradient image. You can see that the dead bone is black in the T1 and also black in the gradient image, diagnostic of stage 4 vascular necrosis of the femoral head. Then we came to the second issue, which is the migratory osteoporosis or the transient osteoporosis. This disease is of unknown etiology. It affects middle-aged males, more common, of course, than females, who are usually overweight, and this is the male to female incidence. This disease is usually unilateral, and it has a predominance for affection of the left hip in females. As I have mentioned, this disease is self-limiting and it resolves spontaneously within 6 to 8 months of non-weight bearing maneuvers for the hip and supportive measures. Then what you will see in this disease by X-ray, you may not appreciate any abnormality, and X-ray may appear absolutely normal, or you may feel some decreased bone density in the affected femoral head and neck. And bone scan will show increased uptake in the femoral head and neck, as you can see here, while bone scan in avascular necrosis will show the photopenic area with decreased uptake in the ischemic part of the bone. Then MRI will show bone marrow edema, which will appear black in the T1 and bright in the T2 and the stair-weighted images. And you remember that we have mentioned that a bone marrow edema in the femoral head and neck may represent an early stage of avascular necrosis, provided that it will progress to the development of the line separating the dead bone from the viable bone. These are some of the informations you should know about the migratory osteoporosis or the transient osteoporosis. As I have mentioned, it is a self-limiting disease, and this is possibly the basis of vascular etiology, maybe the cause. And this is an important statement which indicates that there is still a controversy as to whether it represents an early reversible stage of a vascular necrosis or not. This is the sixth instance, and women are affected usually, but not always, during pregnancy, late in pregnancy, and generally one hip is affected at a time, but there may be an incidence for bilateral hip involvement in the same time, and this disease resolves spontaneously after protected weight bearing. Here is an example of migratory osteoporosis of the left hip, showing diffuse low signal in the femoral head and neck in the T1 weighted images with increased signal in the stair image. Also note the presence of synovial effusion within the affected hip. Then the follow-up study, which is performed I think about 3 months later, and you got total resolution of the changes in the left femoral head. And if you compare the stair images at the time of the disease and the stair images on the follow-up study, you can appreciate the resolution of the disease. Then in the plain X-ray, as I have mentioned, you may not appreciate any abnormality. Look at this example. I think you may feel that both hips appear normal, and you may feel that this femoral neck is relatively osteoporotic compared to this femoral neck. But in the bone scan, you see the typical finding of increased uptake in the femoral head and neck, as you can see, compared to the opposite side. In the MRI, you see the classic picture of low signal, diffuse low signal in the femoral head and the neck on the affected side, which turned bright in the stair images, and you appreciate the presence of synovial effusion. This is migratory osteoporosis by MRI T1, T2 stir, axial T1, axial T2. Of course, the coronal images are more reliable to appreciate the extent of the disease, but also you can feel the abnormality and the femoral head in the axial image compared to the normal side on the left. In migratory osteoporosis may demonstrate a line after clearance of the edema. Then whenever this edema has resolved, there may be a line which can be seen in the femoral head, suggesting the possibility that the transient osteoporosis may precede the development of avascular necrosis and is considered a precursor or an early stage which may be reversible and may progress to the development of the full-blown picture of the disease of the avascular necrosis. And transient osteoporosis, stir images with follow-up after 3 months, and you can see the changes in the left femoral head and neck, bright signal, and total resolution of the disease. Also note that this hip was normal, and in the follow-up study there is some effusion on the right side. Then this is a vascular migratory osteoporosis of the left femoral head and the neck. And after 2 months there is total resolution of the disease, and the follow-up MRI obtained 11 months after the initial one showed the development of migratory osteoporosis in the opposite hip, and hence the name. This is migratory, and the migratory osteoporosis or migratory bone marrow edema can affect one joint, then it may resolve and affect another joint. Then we came to an important issue which is known as the subchondral fracture, and this fracture is considered one of the stress fractures that can affect the femoral head. This fracture is usually parallel to the contour of the femoral head. And of course, if this fracture has developed, it will be associated with diffuse bone marrow edema. Then you have a line and you have bone marrow edema. Then you may go into the way of diagnosing either migratory osteoporosis or even avascular necrosis. Then be careful about this, and this fracture is usually, as I have said, parallel to the femoral cortex, and this fracture on follow-up will show total resolution. And here you can see there is bone marrow edema of the femoral head and neck, and this arrowhead points to this line which represents the subcortical fracture, and this line on follow-up will be more clear, and later on it will resolve completely, and also the edema surrounding the fracture will also resolve completely. So in the literature you will be confronted by this diagram, which indicates that a transient osteoporosis or migratory osteoporosis may progress to avascular necrosis with the development of the line separating the normal bone from the dead bone. Also, the subchondral fracture may progress, if it does not heal, may progress to avascular necrosis. And there is a good overlap between these two. You can miss subchondral fracture and diagnose it as a transient osteoporosis if you could not appreciate the fracture line and you see only bone marrow edema surrounding the fracture. Then this diagram indicates that there is a good percentage of overlap between all of these pathologies, and you should take care not to mistake any of them having all the diagnostic imaging modalities, particularly the bone scan and the MRI, also to have the follow-up studies to confirm your diagnosis. And we came to the osteoarthritis, which is a common disease in the hip, and you know the manifestations of osteoarthritis anywhere in the body, including narrowing of the joint space, and in this joint in particular, the joint space that will be narrowed is here in the superior lateral aspect of the joint. Then superior lateral migration of the femoral head encroaching on this space, osteophytic lipping, subchondral bone sclerosis, subarticular pseudocystic changes, and joint effusion and intra-articular gas or vacuum phenomena. Then the secondary, the osteoarthritis may be primary or secondary to a pre-existing disease like septic arthritis, avascular necrosis, or Bursa's disease. And here you can see you can diagnose secondary osteoarthritis by the age of the patient and the unilateral appearance of the disease and the extensive changes compared to the opposite side. Here you see that there is marked narrowing of the joint space with subarticular bone sclerosis, prominent osteophytic lipping of the articular surfaces. Then one of the important issues is to be able to differentiate between the changes of avascular necrosis and the changes of osteoarthritis. In cases of avascular necrosis, the femoral head is only affected, the acetabulum is usually free. Then also you see this particular site of the joint space, it will be maintained until very late in the disease. But in cases of osteoarthritis, this is a joint disease. It will affect the femoral head as well as the acetabulum. And the changes will appear in the acetabulum, like here you can see pseudocystic changes as well as in the femoral head. This particular site of the joint space will be affected in the disease, and you got marked narrowing of this superior lateral aspect of the joint space. Then there is a specific issue which is known as rapidly destructive osteoarthropathy of the hip, and this is a rare lesion which is usually seen in old women, which indicates that there is osteoarthritis that is rapidly progressive. And here you can see there are osteoarthritic changes. You got pseudocystic changes and flattening collapse and bone sclerosis of the femoral head as well as the acetabulum. In this particular example, you can see that the follow-up X-ray after 2 months showed significant destruction and osteolysis of the femoral head and neck. And what is very important in this particular disease is that biopsy of the joint will not reveal any evidence of infection or crystal disease. And this is known as rapidly destructive osteoarthritis or osteoarthropathy of the hip joint. Then we came to the developmental dysplasia of the hip, which means that there is an abnormal relationship of the femoral head to the acetabulum, and this may be associated with ligamentous laxity and or abnormal position of the baby in utero. This also there is a good association between this abnormality of the hip and the presence of oligohydramnios. The diagnosis is usually made with confidence by ultrasound, and this is the reported incidence, which ranges from 2 to 20 per thousand. And the 60 to 80% of abnormal hips may resolve spontaneously and got the normal relationship between the head and the acetabulum within 2 to 8 weeks after birth. Then what are the risk factors? As I have mentioned, the oligohydramnios is one of the associations or the risk factors: breech presentation, family history, and this disease is appreciably more common in females compared to males. And you know that ultrasound is one of the best imaging modalities for evaluation of the relationship between the femoral head and acetabulum, particularly before the ossification of the capital femoral epiphysis. And also ultrasound allows dynamic examination to assess the stability of the hip and to have stress views for the position where the hip is liable or prone to dislocate. Then by the plain X-ray, you are able to assess the developmental dysplasia of the hip, especially whenever you have some ossification in the femoral capital epiphysis. We usually draw a line which is horizontal at the roof of the acetabulum and draw a perpendicular line to this one touching the iliac bone. And normally the capital femoral epiphysis will be in the lower inner quadrant of this diagram. Then these are the two lines. One is touching the acetabular or the triradiate cartilage of the acetabulum, and another line which is perpendicular to it. Then normally you will see the femoral head within the lower inner quadrant of this diagram. Then also you can measure the acetabular angle, which is usually less than 30 degrees at birth and should progressively reduce with maturation of the hip. But if the acetabulum is dysplastic, then you got shallow acetabulum with much more angle in this angle. And the angle is drawn between the line going through the triradiate cartilage of the acetabulum and another line which is done along the roof of the acetabulum, and this is the acetabular angle. Also, this Shenton line is very famous. We draw a line passing from the inferior medial aspect of the femoral neck going to the inferior border of the pubic ramus, the superior pubic ramus, and the lateral margin of the pubic bone. This line should normally form a gentle curve. It will not be discontinuous. Then you consider that the femoral head is in a normal location. And without drawing any lines, you may appreciate the appearance of the left femoral head that is away from the acetabulum. Then drawing the usual lines, and you see that the femoral head, instead of being here, it is now in this position, meaning that it is dislocated. And also you can see this is the normal hip and this is the capital femoral epiphysis, which is normal. But here in the dislocated hip you got a small capital femoral epiphysis area of ossification, and there is a bad relation between the femur and the acetabulum. And the congenital hip dysplasia is one of the diseases that may be resolving spontaneously, or with certain measurements you can reach this prognosis. Here you see dislocated hip, and this is the follow-up after 26 months, and this is the follow-up after 4 years. Here you see that the capital femoral epiphysis is developing normally. It has normal size and bone density, but its articulation with the acetabulum is somewhat distorted, but you got finally a near normal appearance of the hip. Then leg calvé burst disease means that there is a vascular necrosis of the capital femoral epiphysis in the pediatric age group. It is of unknown etiology, and the children are affected at this age from 4 to 9 years old. Boys are more commonly affected than girls. The changes in the capital femoral epiphysis are almost similar to any vascular necrosis elsewhere, where you got fissures, abnormal bone density, structural collapse, and fragmentation in the advanced stages of the disease. As I have mentioned, the etiology is unclear. It's not related to the causes seen in adult population. Idiopathic osteonecrosis of the capital femoral epiphysis is the diagnosis, and bilateral involvement may occur in about 15 to 20% of the patients. Males are more commonly affected than females. We have 4 stages for burst disease, and stage 1 means that there is affection of a part of the epiphysis, and stage 2 means that there is affection of a part of the epiphysis associated with metaphyseal reaction or irregularity. In stage 3, the whole epiphysis will be affected together with metaphyseal reaction, and in stage 4 you got flattening, collapse, and bone sclerosis. Then if you look here, and you can see that the capital femoral epiphysis is relatively smaller compared to that on the right side. And also if you look to the metaphyseal end of the femur, you see these irregularities. Then all the epiphysis is affected with metaphyseal reaction, and you consider stage 3 burst disease. And here you see extensive flattening and collapse of the capital femoral epiphysis, meaning that this is stage 4. And this is stage 4 burst disease of the left hip. You see flattening, collapse, fissures, sclerosis of the capital femoral epiphysis together with this metaphyseal reaction. Burst disease can also be treated conservatively, considering the non-weight bearing maneuvers as well as the supportive measures, and you may got complete healing on follow-up studies. And this is an example. You see the initial X-ray showing stage 4 burst disease with flattening and collapse of the femoral head. Then 2 months, 10 months, and 15 months follow-up, you got almost appearance or recovery of the capital femoral epiphysis, which is more or less of normal size. It shows mild increased bone density. It is well co-opted within the acetabulum, as you can see. And MRI is helpful for evaluation of early stages of a vascular necrosis in adults as well as in the pediatric age group. In cases the plain X-rays are normal, MRI can show early changes in the capital femoral epiphysis. And also here you see this is the normal capital femoral epiphysis, and this is the affected right side with a stage 4 avascular necrosis, collapse, decrease bone signal denoting bone sclerosis. And this is a stage 4 burst disease with severe collapse, fragmentation, and sclerosis of the capital femoral epiphysis compared to the normal one on the opposite side. Then we came to the issue of slipped capital femoral epiphysis, and this means that the capital femoral epiphysis is no more co-opting with the femoral head. And this is the normal appearance on the right side, and this is the slipping of the capital femoral epiphysis on the left side. The actual cause is not usually not usually appreciated by the patient, and it may be due to some mild trauma, or in obese patients, for example. And bilateral slipped capital femoral epiphysis can be seen in about 25% of the cases. And whenever the epiphysis is slipped, it's liable for avascular necrosis as well. This is a male, 11 years old, and you can appreciate very easily the slippage of the capital femoral epiphysis on the left side. And usually you need to have this position, which is known as the frog leg view, or you consider it as a lateral view for the hip, in order to appreciate the slippage more easily than the frontal view. And in the frontal view, you can see that the capital femoral epiphysis is in its normal position, but here you appreciate the appearance of the slippage. And this is one of the helpful techniques whenever you are suspecting slipped capital femoral epiphysis. You draw this line tangential to the superior aspect of the femoral neck. And if the capital femoral epiphysis is in its normal position, this line will cut part of the epiphysis. But if the epiphysis is slipped, and this usually occurs inferior medial, then the line will not cut part of the epiphysis. This just a helpful maneuver. Then this is an easy diagnosis, bilateral slipped capital femoral epiphysis, as seen by this plain X-ray. In my opinion, the axial images of the CT scan are more helpful than plain X-rays and even MRI in the diagnosis of slipped capital femoral epiphysis. In the plain film of this example, you will feel that this epiphysis is slipping, and also you can see this by MRI, and here is the axial CT scan. You can see the slipped capital femoral epiphysis of the same case. Then we came to an issue which is known as the proximal focal femoral deficiency syndrome. From its name, you know that there is some deficiency in the proximal part of the femur, and according to the deficient part, there are some classifications and the grading of this disease, which is which indicates that there is a congenital absence of the proximal part of the femur, whether it includes the head and neck and part of the shaft, or one of the three. This will result in shortening of the affected limb, and this the etiology is usually unknown. The diagnosis and the classification are based mainly on the brain film finding. These are the classifications written in the books. They include type 1 or type A, B, C, and D. Then we'll discuss these types, and the type or the class 1 or type 1 is the less severe or the mild form. Then by progression or advancement of the disease, you got type B3, type B, C, and D. In this class A or type A, the femoral head is present, and this is important. And the head is attached to the shaft by the femoral neck. Also, the femoral neck is present, and the femur is shortened. There is coxa vara deformity, as you can see. The neck is cartilaginous. You can see some part of the neck, but you cannot see the rest of the neck. And this cartilaginous connection may form a subtrochanteric pseudoarthrosis, false joint between the neck and the shaft of the femur. Then the limb is shortened. There is femoral head. The acetabulum is good, and the femoral head and neck are well developed, and there is some cartilaginous part here. There is some pseudo articulation between the femoral neck and the shaft. in this reconstructed image, and you got shortening of the limb. The femur is very short compared to that on the right side. Also, one of the associations of this disease is absence of the fibula, but in this particular example, the fibula is hidden behind the femur. In class B, the acetabulum is adequately or a little bit distorted. The femoral head is also present. There is no osseous connection between the femoral head and the shaft, meaning that the femoral neck is not ossified. The femoral segment is short and usually has a bulbous bony tuft. Like this one, you may feel that this is class B. And in class C, the acetabulum is dysplastic. The acetabulum is not or is very shallow, and as you can see here, the femoral head is absent or very small. The head is not attached to the femoral shaft. The shortened femoral segment has a tapered proximal end, as you can see here and you can see here. Then this is the class C. You see the acetabulum is markedly dysplastic or very shallow. You cannot see the femoral head or neck. You can see only part of the lower or the distant femoral shaft, as you can see, with considerable shortening of the limb with tapered or pointing end of the femur. In class D, and this is the most severe type, there is no acetabulum. The acetabulum is not formed. There is no proximal femur. Only part of the distal femur is present with pointing or tapered end, as you can see. Sometimes you will be confronted by a patient having the proximal femoral deficiency syndrome, and the changes cannot fit with any of the previously mentioned classes. Then you just mention that this is a proximal femoral deficiency syndrome, and you mention the findings. Like in this case, there is no acetabulum, there is no femoral head, there is no femoral neck, and the proximal end of the shaft is bulbous, and the limb is shortened. The femoral shaft is displaced severely away from the supposed acetabulum. Then if you want to classify this appearance, and you can go by this way. Is the femoral head is present? Yes. And the head is attached to the shaft by the neck? Yes. And the femur is shortened? Okay. Then is there any coxavara deformity? No. Is there a cartilaginous neck which will articulate with the shaft? No. And there is no pseudoarthrosis. Then the limb is short and the femur is almost normal. The acetabulum is almost normal apart from being short. Then which class? This one you cannot fit with any of these of the previously mentioned classes. As I have mentioned, you only say what you see. Then we came to the muscle sprains, and we have 3 grades of muscle injury which may affect commonly the muscles. Here you remember the obturator internus, obturator externus, and the adductor brevis. In grade 1 muscle injury, there is muscle edema, low signal in the T1, high signal in the T2. In grade 2 muscle injury, there is muscle hematoma, high signal of blood in the T1 and T2 with the images. In grade 3, there is muscle tear, retraction, and atrophy of the affected muscle. And this is grade 1 or muscle sprain or muscle edema. The muscle will appear. You will not appreciate any signal changes in the T1, but you will see. Sorry, this is the right side, this is the left side, and you can see here that the biceps femur showing bright signal in the T2 fat set images, denoting muscle edema. And here in the T1 and T2 with the images, you see high signal hematoma in the anterior compartment of the thigh, the hemorrhage is of bright signal in both pulse sequences. This is grade 3 muscle injury. The rectus femoris muscle in this area is showing abnormal signal, and it is relatively atrophic compared to the normal rectus femoris muscle, you remember. Then, considering the fractures around the hip, one important issue is that the femoral neck is intra-articular, and any fractures around the femoral neck will be intra-articular as well, or intracapsular. This is an important information for the surgeon. He needs to know whether there are bone fragments inside the capsule or not. And you know that this is the anterior column of the acetabulum, this is the posterior column, and this is the quadrilateral blade. And here you got fracture anterior column and fracture posterior column as well. You may use the facilities of multi-detector CT in reconstructing the images to see more better. And I should say that the most valuable reconstructed images are the 2D images in the coronal and the sagittal views. And you should remember that the 3D images are of little diagnostic value. Then some of the bone tumors around the hip, I will discuss the bone tumors in a separate lecture, but this is just an example of lymphoma of the iliac bone. You see that there is patchy areas of bone sclerosis. Sclerosis is one of the features of lymphoma, and you got extraosseous soft tissue component outside the pelvis as well as inside the pelvis. In the T1 weighted image, you see the bone marrow infiltration by lymphoma and the extraosseous soft tissue component. And in the STIR images, you got increased signal of the tumor as well as its extraosseous part. Then in this CT scan, you see an osteolytic lesion in the anterior column of the acetabulum. This lesion is more or less expanding with erosion or breaching of the cortex. The MRI showed that there are multiple fluid levels inside the lesion, diagnostic of an aneurysmal bone cyst. Metastatic deposits can be sclerotic or osteolytic or mixed, and this is a case of prostatic cancer showing osteosclerotic bone deposits scattered in the pelvic bones as well as in the proximal femora. Whenever you are in need to evaluate the acetabulum labrium, then you should have an MR arthrogram. And this diagram shows the point where we inject contrast media in the hip joint. Then the contrast media usually include about just 0.1 milliliter of gadolinium and 20 milliliters of saline, and you add 5 milliliter of iodinated contrast media in order to see the injection or the flow of contrast under the screen control. Then you know that the capacity of the hip joint is about 8 to 20 millimeter. After injection of contrast, you use a surface coil to scan only the desired hip, and then you will select a suitable field of view which ranges from 14 to 16 centimeter, and this is the slice thickness from 3 to 5 millimeter, and you use T1 weighted images with or without fat suppression, and you scan in the axial, sagittal, and the coronal planes. Then this is the surface coil, and this is the scanning. You see the normal labrum as a triangular low signal intensity attached to the superior and the inferior margins of the acetabulum. And here you can see the normal acetabular labrium, which is triangular in shape and is of low signal intensity in all pulse sequences. Then if you see some signal changes within or at the base of the labrium. If the signal is intermediate, and you think of degeneration. If it is bright or of fluid signal, and you think of tear. Also, if you identified what is known as paralabral cyst, and this cystic or localized collection of contrast at the site of the labrium is an indication of labral tear. And you know that the hip joint is the one of the joints that is surrounded by too many bursae. And the important one of all of these is the iliopsoas bursa, which is considered the largest bursa in the body. You know that there is a lesser trochanteric bursa, which is adjacent to the lesser trochanter, and you remember that bursa will not usually be seen unless if it is inflamed or filled with fluid. And the common cause for fluid accumulation in the bursa is inflammation, of course. And this is one of the known bursae around the hip, which is the greater trochanteric bursa, located subcutaneously at the site of the greater trochanter. And remember the muscle which is lateral to the femoral vessels, and this is the iliopsoas. And the iliopsoas bursa is just between the vessels and the muscle. This is the location of the iliopsoas bursa. And the iliopsoas bursa is sometimes continuous with the hip joint. And if this is the case, then hip joint effusion will be decompressed in the bursa itself. And as has been mentioned, that this bursa is the largest bursa in the body. And you can see here there is a large hip joint effusion and is extending, filling the iliopsoas bursa in this patient known to have rheumatoid arthritis. This is MRI axial and coronal views showing the iliopsoas bursa, which is filled by high signal fluid. Loose bodies in the hip are also commonly seen in the clinical practice, which are usually the sequelae of osteoarthritis, sometimes trauma, or the presence of avascular necrosis. And also the hip is one of the joints affected commonly by synovial osteochondromatosis. A loose body like this one in the hip joint may be the source of pain, locking, clicking, and snapping of the hip joint. And if there are a lot of loose bodies within the hip, you are dealing with synovial osteochondromatosis, which is a disease secondary to synovial metaplasia, leading to the formation of cartilage, which later on calcifies. The imaging findings will include widening of the joint space early in the disease, erosive changes of the articular bones, intra-articular many loose bodies that are calcified, and late in the disease you got secondary osteoarthritic changes. This is synovial osteochondromatosis of the hip. You can see that the hip joint capsule is markedly distended, and there are a lot of radiopaque calcified loose bodies within the joint. And this is also another example. You see some fluid within the joint associated with too many loose bodies within the hip. Also, this is an example. You can see the loose bodies. You see the distension of the hip joint capsule on the left side, and in the coronal image you can appreciate also the loose bodies. This is MRI sagittal view showing too many loose bodies within this hip, which contains a lot of fluid also due to effusion. And finally we came to the femoral neck anteversion angle, and you know that there is a small angle between the femoral head and the horizontal plane, and this diagram shows the anteversion angle of the femoral head, in relation to the tangential line to the femoral condyle, and this angle is in the range of 15 degrees according to the age of the patient. If this angle is increased, then you got a femoral neck anteversion. If there is no angle at all, then you get femoral neck retroversion. And whenever you put the femur on the table, you got some angle between the femoral neck and the table. This is known as the anteversion angle, and you can see in this femur the anteversion angle is very large, and there is a large angle between the femoral neck and the table. We used to measure this anteversion angle by doing this scan. We put the patient in the supine position on the CT machine. We have the scanogram, then we have sections in the hip and sections in the knee. Then we draw a line in the middle part of the femoral condyle at the level of the patella, and another line going through the femoral neck. As you can see here, we want to measure the angle between the neck and the table, which is represented here by the femoral condyle. And this is another way which is presented in the book. It's more easy. You have a scan in the knee at the level of the patella, and a scan in the hip. You draw a line going through the femoral neck, and another line tangential to the femoral condyle, which corresponds to the table. Then you measure the angle between this line and that line, and this is the femoral neck anteversion angle. This table shows the normal anteversion angle in relation to the age. The angle is large early in the life, and it decreases progressively until it is about 8 degrees by the age of 20 years. هذا وبالله التوفيق والحمد لله رب العالمين. Thank you very much.